Continuing our discussion of the comprehensive metabolic panel, we are going to turn our focus to diagnostics in regards to blood glucose or blood sugar, kidney function, as well as liver function. Looking at blood glucose or blood sugar, this is the most frequently ordered chemistry test. We'll find that levels in the plasma or serum are higher than levels in the whole blood. And we can see that levels are controlled as a reminder of contrasting actions from insulin and glucagon being released from the pancreas. There are secondary influences from other organ systems. We think of the adrenal glands or adrenal system with ACTH, our adrenal corticosteroids, as well as our thyroid glands, thyroxine, and even our autonomic nervous system, epinephrine. So there's a lot of things to consider when we look at interpreting blood glucose values. A lot of times when we're looking at blood glucose values, we're trying to rule in or rule out either type 1 or type 2 diabetes. A reminder, type 1 diabetes, we see beta cell destruction. This is an autoimmune process versus type 2 diabetes, we see a progressive insulin secretory defect. And then that leads to cellular resistance or insulin resistance over time. There are some other specific types of diabetes, though, or subtypes. There are genetic defects that can occur in beta cell functioning, affecting insulin. There are diseases that can happen to the exocrine pancreas that can have an effect on the endocrine action. And then there's also drug or chemical induced causes. Also, gestational diabetes is something that we screen for and look for in pregnant individuals. Looking at kind of our natural history of type 2 diabetes, we can see over the course of 4 to 7 years, kind of this onset of insulin secretion increasing while we have impaired glucose tolerance and undiagnosed diabetes. Insulin resistance starts to occur. And then kind of over this time as well, we have this postprandial glucose or post-meal glucose and fasting glucose that really doesn't do anything to this at the start, but then starts to rise kind of in this undiagnosed stage and then really increases up once we have kind of that known diagnostic. When looking at a reference range for insulin levels, we can see that related to fasting versus meal times, we can see that our insulin levels are going to be relatively low in a fasting state versus as we increase our time right after meals, we can see that that level is going to increase and then it will decrease back down close to that fasting state. Therefore, we can expect that our blood glucose will similarly rise and fall post meals or postprandial. Typically, when we're ordering a fasting blood glucose, we're looking for a minimum of an 8-hour fast. We see diabetes mellitus as a diagnosis if fasting blood glucose is greater than 126 milligrams per deciliter on two separate occasions. Kind of how we diagnose blood pressure, where we need two separate elevated readings, very similar to fasting blood glucose. Prediabetes is kind of impaired fasting glucose, where we can see ranges of 100 to 125. Some normal ranges are listed here. We can see the differences between children and adults. We're looking at 70 to 100 being kind of our normal reference range. Optimal would be between 80 and 100 in a fasting state. Some interfering factors with glucose analyses include stress and caffeine intake. Pregnancy can lead to glucose intolerance. Failure to appropriately separate serum from cells in a timely manner. So this is, paying attention to when we collect blood in the serum SST tube. We want to invert 5 times, leave out for a specific amount of time, and then spin it down in a centrifuge. If we don't do that in a timely manner, we can see a false decrease of glucose. IV fluids with dextrose and certain drugs or medications can also affect glucose analysis. Now, if we do a casual plasma glucose, this is considered or defined as any time of day without regard to the time since our last meal. So we're really not paying attention to fasting. You're looking for an abnormal state of anything that's greater than 200, in addition to symptoms of diabetes, such as polyuria, polydipsia, or unexplained weight loss. You then would confirm on a subsequent visit with a fasting blood glucose or an oral glucose tolerance test. Glucose tolerance testing is considered for adults that have impaired fasting blood glucose and during pregnancy if the patient's at risk. The procedure is you have an 8-hour fast, then you do a glucose dose, which is 75-gram dose, and then you test the glucose at 2 hours to see if it's elevated. The diagnostic criteria for an oral glucose tolerance test, diabetes if glucose is greater than 200 at 2 hours. Um, Impaired glucose tolerance, if we're in that 140 to 199, so it's pre-diabetes essentially at 2 hours. Normal if we're less than 140. And anytime we consider impaired glucose tolerance or impaired fasting glucose, we would call that now pre-diabetic. That was kind of the previous term, but now we really try to define them a little bit more specifically. Another consideration for blood glucose or for diabetes screening is the hemoglobin A1C. This is glycated hemoglobin or hemoglobin that has a glucose bound to it. We can think about then our lifespan of red blood cells around 120 days or 4 months. Glycosylation of blood proteins is in proportion to our blood glucose concentration, and it gives kind of a 3 to 4 month window of what sugar has been doing over the course of that time. Normal is 5%. Goal for diabetics is less than 7%. Someone who's pre-diabetic, they have a value of 5.7%. Anything above 6%, we would consider that being positive for diabetes. So a hemoglobin A1C test measures the amount of blood glucose attached to hemoglobin in a red blood cell, and we get a percentage, and it's our average daily blood glucose level over the past 3 months. So again, 6% would correspond to a range of 135, 8% a range of over 200, 10% over 240, not good, 13% or more dangerous, right? So as we go up in percentage of glycosylation, we are more concerned about those essentially the blood sugar status of that person. And this is showing just a comparison of relative risk progression of diabetes complications based off of mean A1C value. So an A1C value of 6% at diagnostic range for diabetes, we have a very low relative risk, less than 2% for these complications. But as we increase, if we get up to 12%, we can see our relative risk for retinopathy, for instance, has increased from 1% to 20%. 1 in 5 individuals with a A1C of 12% or greater will have retinopathy or eye issues. 15% have kidney problems. About 10% will have nerve damage, and we'll start to see protein spillover in the urine at about 5% at that 12% A1C range. So looking at our criteria for diagnostics, and again, this updates and changes fairly frequently. So I encourage you to go to the American Association for Diabetes or Up to Date for the most accurate numbers when you are diagnosing your patient every time. But an A1C of 6.5% or greater is considered diagnostic for diabetes. Some values will say above 6%. Fasting plasma glucose above 126, or a 2 hour plasma glucose of greater than 200, or random plasma glucose of greater than 200, but you need two values, two separate times for that one. But these would be considered your diagnostics for diabetes. And then we're looking at diabetes mellitus type 2 or type 1, depending on if we're thinking autoimmune or if we're thinking lifestyle. So some categories of risk for individuals who are kind of in that pre-diabetic range. If you had a fasting plasma glucose of 100 to 125, that's impaired fasting glucose. Or if you had a 2 hour plasma glucose test of 140 to 199, that's impaired glucose tolerance, or an A1C of 5.7 to 6.4. That would be considered pre-diabetic. Now, for gestational diabetes, we screen for undiagnosed type 2 diabetes at the first prenatal visit, and those with risk factors. We use standard diagnostic criteria here. And in pregnant women not previously known to have diabetes, we would screen for gestational diabetes mellitus at 24 to 28 weeks gestation, and we use a 75-gram oral glucose tolerance test. So this is kind of our standard. We screen women for gestational diabetes and persistent diabetes at 6 to 12 weeks postpartum using a test other than an A1C. A woman with a history of gestational diabetes should have lifelong screenings at least every 3 years. The standard is 5. So this is a slightly smaller screening window. And these are some screening options for the diagnosis of gestational diabetes. You can do a 75-gram oral glucose tolerance test with plasma glucose measurement fasting and at 1 and 2 hours at 24 to 28 weeks gestation. And this is someone who's not been previously diagnosed. You should perform this in the morning after an overnight fast of 8 hours. And this is what you're looking at for the values. And this is if you have any one of these values, you'd be given a diagnosis of gestational diabetes. It's interesting now, there are some different kind of various measures of screening. There are smart contact lenses that can double as a non-invasive glucometer. There are our continuous glucose monitors that we can attach to our skin, typically on the back of our arms. So there's lots of different ways to screen for diabetes and to also manage sugar. Oftentimes these tools, while really convenient for patients and it avoids having to do finger stick glucose all the time, which now we know isn't super fun. They are often expensive and not always covered by insurance. So that is the barrier. When we come back, we will start looking at our kidney evaluation biomarkers.